According to VERICOM's material safety data sheet, where root ST contains 50 to 60% calcium silicate content, which is considered one of the highest PC sealers worldwide in calcium silicate content. What is hydraulics? Our basic technique is the hydraulic condensation. So what is hydraulics? Simply, hydraulics is the injection of the bioceramic sealer into the root canal system, then applying your master cone gutta-percha to the full working length, which act as a piston that push the sealer into any susceptible microanatomy that may exist. Is it powerful enough to get a 3D obturation? Let's find out. Here is a quick video that shows the sealer flowability and consistency while injected in a plastic block where 3 lateral canals were simulated, just injection of the sealer only without adding any gutta-percha. Look the sealer how it flows through the long lateral canals. After that, you put your master cone to the full working length. Sear off the gutta-percha at the orifice level and do some coronal compaction and you're done. You're finished. Just 10 seconds and you're done. Here are the examples. Here's the lateral canal filled related to upper lateral incisor. Lateral canal filled related to upper canine. Here are 2 lateral exits filled related to lower first premolar. Here are 2 lateral canals filled related to upper second premolar. Isthmus area filled related to upper first premolar, just with the sealer. Lateral canal filled and the apical delta filled related to the mesial and the distal root of lower second molar. Here's a lateral canal filled related to the mesial root, and here is a 3-year recall. The lateral canal is still filled with the sealer, and the sealer did not washed out, did not resorb, which is very important for the sealer to last. Here is the lateral canal filled related to the mesial root, and an isthmus area was completely filled with the sealer. And here is a 5 months recall. The lateral canal is still filled with the sealer, and there is complete healing. Here are 3 lateral canals filled related to the distal root. Here is a lateral canal filled related to upper first molar with 4 roots related to the palatal canal. This is a type C lower second molar. I wasn't able to achieve patency. So I injected the sealer and added tapered auxiliaries. I just added the sealer and added tapered auxiliaries. No exits were filled. After I seared off the gutta-percha and I did coronal compaction, there are 2 lateral exits were filled with the sealer, as you see here. And here is a 3 months recall after indirect composite restoration. This case also, I wasn't able to achieve patency in the distal root. After I injected the sealer, seared off the gutta-percha, look what I got. This is a tortuous lateral exit that was filled with the sealer, which was nearly impossible to be negotiated with hand files. No file can go through there. In this case also, I wasn't able to achieve patency in the distal root. After I injected the sealer, I got an abrupt 90-degree lateral exit that was filled with the sealer. Lateral canal and lateral exits filled using root ST. Third exit related to the distal root. Here is an loop filled related to the mesopaccal root. Here is a variety of upper central incisors. Upper central incisors has more than 40% incidence of accessory canal. Most of upper central incisors has such variation, such microanatomy. Where root ST will help you achieve the optimum apical seal in almost all types of cases, especially in the following case scenario. Long roots more than 25 millimeter, extremely curved roots, multi-planar curvature, H-shaped curvature. In case of conservative shaping, teeth with external root resorption, compromised roots for strengthening, large periapical lesions as it promotes healing, and in cases of limited accessibility and limited mouth opening. This is a multi-planar curvature combined by conservative shaping related to upper first molar. How will you obturate such anatomy? Here, multi-planar curvature combined by conservative shaping related to lower second molar. multi-planar curvature combined by conservative shaping related to lower first molar. Cases of long roots, this canine was 32 millimeter in length. Again, long and curved roots. Separated file retrieval. When we remove or retrieve a separated file, we lose some dentin. We compensate the lost dentin using bioceramics as it bonds to dentin and act as a mono block, so it strengthens the root. Here, after I retrieve the separated file, we compensate the lost dentin using bioceramics. And here is the immediate post-obturation. The 1 year recall shows complete healing. Here also, after we retrieve the separated file, we compensate the lost dentin using bioceramics. And here is the sealer flows through a furcal canal related to the furcal radiolucency. And this is 1 month recall after crown placement. This case has a different scenario. Look at the size of the radiolucency. It's very large, it's very huge. After I retrieved the separated file, the canals were oozing exudate, and I had to finish in 1 visit. So I injected the sealer and finished the case. This is 8 months recall, shows complete healing. The sealer is still the same, did not washed out, did not resorb, which is a very, very tough test for any bioceramic sealer to withstand such tough circumstances. The sealer can be easily washed out due to the exudates that exist in the canal. But thanks to the consistency and the high percentage of the calcium silicate that allowed the sealer to set without being washed out. Here also, after we retrieved the separated file, we compensated the lost dentin using bioceramics. This is a retreatment case that went from simple to very difficult. During getaperca removal, I separated 4 instruments in the mesiolingual canal, and 1 instrument goes beyond the distal apical foramen. I managed to retrieve all 5 instruments and finished the case. And here is a quick video that shows the retrieval of the 5 instruments. This is the ultrasonic tip number 1. This is a wired loop device to remove getaperca, to remove the separated file from the getaperca. So this is file number 2. This is file number 3, the one that goes beyond the distal apical foramen. Here's after retrieval. And files number 4 and 5. In case of limited accessibility and limited mouth opening, this is a lower wisdom. This is the tough lower wisdom. This is another wisdom with anastomosis related to the mesial and the distal roots. Healing of a large lesions, as you see, the 2-year recall shows complete healing. This is the 3 months recall, shows significant reduction in radiolucency size. And this is 1-year recall, shows complete healing. The sealer did not prevent the healing, but despite it promotes the healing. PC sealer is an orthopedic bone cement in its origin. So it's a bone cement. So it will never retard the healing. This also, healing of a large radiolucency related to the distal root. This case also is healing after 8 months despite the separated file and the mesial root. Look here, is the immediate post-obturation. This is 8 months recall, shows healing. This is a 4-year recall, shows also healing. This is the 8 months recall for a furcal bone remodeling. After 8 months, the complete furcal bone was regenerated again. This is a lower wisdom, by the way. This is another retreatment, and 1.5 year recall shows healing. Okay. Anyone here practicing vital bulb therapy? Raise your hands, please. 1, 2. That's unfortunate. Okay. Please pay attention to this part of the lecture. After this part, I assume you will do about your 70% of your root canal cases to vital bulb therapy cases. So please pay attention. American Association of Endodontists position statement on vital bulb therapy. Vital bulb therapy techniques are means of preserving the vitality and function of the dental bulb after injury resulting from trauma, caries, or restorative procedure. Vital bulb therapy procedures have traditionally included direct, indirect bulb capping, partial and complete pulpotomy. We have 5 steps to do in one single visit. Once you did it correctly, you have a successful vital bulb therapy case. Number 1, diagnostic consideration for vital bulb therapy. You should have sound diagnosis. The current AE diagnostic terminology assigns a vital bulb to one of 3 categories: normal, reversible bulbites, irreversible bulbites. Number 2, caries management, complete caries removal. Any residual caries left behind will affect your prognosis and will lead to failure later on. So you need to remove all the decay. Number 3, use of sodium hypochlorite. Sodium hypochlorite is an antimicrobial solution that provides hemostasis and disinfection of the dentin bulb interface. Hemostasis can be achieved within 5 to 10 minutes, either via direct passive irrigation or in a sodium hypochlorite dissolved cotton pellet. Number 4, you will put your calcium silicate cement or your bioceramic material on the exposed bulb. Number 5, you will do immediate restoration, which has the advantage of prevention of the micro leakage, protection of the biomaterial layer, reduction of the post-operative sensitivity and thermal conductivity. The primary goal of vital bulb therapy techniques is the creation of optimal conditions for bulb tissue repair and preservation. This paragraph is very important. A pre-treatment diagnosis of irreversible bulbites is not necessarily an indication for pulpectomy, as more conservative treatment could be considered. What they mean by that? They mean they can do partial or complete pulpotomy in cases with irreversible bulbites. Okay. What would be 2 different clinical applications? Direct bulb capping for upper second premolar, exposure site, capped with putty, immediate post restoration, immediate post X-ray. Direct bulb capping for upper first molar, exposure site, capped with putty, immediate post restoration, immediate post X-ray. This is a 2-year recall. Tooth was completely asymptomatic, responds normally to cold with no any radiographic finding, and this is a successful vital bulb therapy case. Look at this case for a young age, 16 years old girl. The X-ray on the left is immediate post-direct bulb capping. The X-ray on the right is 4-year recall. Look, the bulb horn is intact again. Here, the capping material is inside. Here, it's intact again. And the tooth was completely asymptomatic, responds normal to cold with no any radiographic finding. This is what we call barrier. This is not dentin, this is barrier. Here also, 1-year recall. As you see, there is a barrier formed and no signs and symptoms of apical or irreversible bulbites. This is direct bulb capping for lower second premolar. Direct bulb capping for upper first molar. This is a 3-year recall. Tooth was completely asymptomatic. Direct bulb capping in the aesthetic zone. In the aesthetic zone. Here again, direct bulb capping for upper central incisor. The X-ray on the right is 1-year recall. As you see, there is a narrowing in the bulb chamber, indicating barrier formation, and the tooth also was completely asymptomatic, responds normally to cold, with no any radiographic finding. And this is 1-year recall clinical image. No discoloration occurred in the central. This is a trauma case for a 9-year-old girl. She came like this one. I did complete pulpotomy, and here is the immediate post pulpotomy. As you see, there is incomplete maturation of post roots. There is an open apex of post roots. This is the 9 months recall, shows complete maturation of post roots. And there is no discoloration occurred in the central, so you are free to use this material in the aesthetic zone with no fear of discoloration. Unlike most MTA brands causes massive discoloration, even white MTA causes such massive discoloration. Direct bulb capping for lower second molar. As you see, there is a barrier formed. Look at the red arrow pointing at the barrier. This is also direct pulp capping for lower first molar. The X-ray on the left is 1.5 year recall. On the right is 4 year recall. The tooth was completely asymptomatic. Okay. Here is a 50 years old male who came complaining severe pain related to his lower second molar. Upon taking a radiograph, I found a deep carious lesion near the bulb related to the first molar. Now, what will be your treatment plan here, knowing that the first molar was completely asymptomatic? Simply, I did root canal treatment to the lower second molar as the bulb was unhealthy and inflamed. Look at the blood color. While I did direct pulp capping to the lower first molar as the bulb was healthy and could be kept alive, so I did direct pulp capping. You should take care while addressing the carious site, so you should be away from the projected distal bulb. You need to tilt your hand a little to avoid exposure of the whole bulb in this area, so you won't be able to do capping. This is a 1 year recall. Both teeth are completely asymptomatic. Both are with no any radiographic finding, and the first molar responds normal to cold. This is a 2 year recall, the same, and there is a barrier was formed. Here is a barrier. This is the barrier that was formed. The red arrow pointing at the barrier after 2 years. Direct pulp capping for lower first molar, partial bulbotomy for upper first premolar, partial bulbotomy for lower first premolar, 1 year follow-up, complete bulbotomy for upper first premolar, complete bulbotomy for upper second premolar, partial bulbotomy for upper first molar. Here is a 6 months recall. Partial bulbotomy for upper first molar. Again, partial bulbotomy for upper first molar. Complete bulbotomy for upper first molar. It's a repeatable and a repeatable procedure. Look how deep was this margin. We did also partial bulbotomy. Complete bulbotomy for upper first molar. Even in cases with fractured cusp. This case has a fractured mesolingual cusp, as you see here. Of course, exposure occurred. This is an exposure. But we were able to maintain vitality, and we did complete bulbotomy, and the patient was completely asymptomatic. Starting from this case, the diagnosis is irreversible bulbitis, and all teeth were symptomatic. Look, the amount and the color of the blood, it's very profuse and dark red bleeding. After I removed all the coronal bulb tissue, I was able to get a firmly attached and homogeneous bulb that can I apply to do complete bulbotomy. And we did complete bulbotomy despite of the symptoms. Same scenario. Again, same scenario. All these cases are irreversibly. In cases also of bulb stone, this case has a bulb stone, as you see here. After we removed the bulb stone, removed all the inflamed coronal bulb tissue, attachment check, we did complete bulbotomy. We did partial bulbotomy in such case with irreversible bulbitis. Complete bulbotomy for lower second molar. Complete bulbotomy for upper first premolar. And this is what I do in vital bulb therapy cases. You take part of the body, it's a pre-mixed bioceramic material, just compacted using adhesive brush. If you need more increment, you can add, no problem. You adapt the material. Slight wettening to initiate the setting reaction of the material. And we start removing the excess material using another adhesive brush. We remove excess material to enhance the bonding because we are going to do the final restoration in the same visit. You can protect your material using any light cured liner, glass ionomer, calcium hydroxide, Ceracal, or whatever. Curing, more cleaning, you can do also sandblasting. and you're done, and the tooth is ready to receive your final restoration. Okay. Root canal treatment and vital bulb therapy in the same case. Can we do that? Can we do root canal treatment and vital bulb therapy in the same tooth? Okay, let's find out. Here is a 9-year-old boy who came complaining severe pain that awakes related to his lower first molar. Upon taking radiograph, I found a deep carious lesion near the bulb and the incomplete maturation of the distal root. As you see, the apex not fully formed yet. Upon exposure, dark red profuse bleeding came out with little amount of pus. After accessing the tooth, dark red profuse bleeding came out. The clinical image on the right is after trials to control the bleeding. This image on the left told me that the mesial bulb is unhealthy and has to be removed, while the distal bulb is healthy and could be kept alive. So I did root canal treatment to the mesial root only, while I did capping to the distal root. Confit X-ray, and here is the immediate post-obturation and capping for both, with both using ST and PT. The X-ray on the left is 18 days recall. The X-ray on the right is 1 month recall after a stainless steel crown placement. The boy was completely asymptomatic. And here is the clinical research that supports the procedure. Combination of non-surgical endodontic and vital bulb therapy for management of mature permanent mandibular molar teeth with symptomatic irreversible bulbites and apical periodontitis. And here is the 14 months recall. There is complete maturation of the distal root. This means that the distal bulb stayed alive and continued the growth of the distal root. The X-ray on the left is 1 month recall. The X-ray on the right is 14 months recall. I think the difference is crystal clear. Here is a part of the literature about vital bulb therapy. Treatment outcome following direct bulb capping using bioceramic materials in mature permanent teeth with carious exposure, retrospective study. Success of direct bulb capping using mineral oxide aggregate and calcium hydroxide in mature permanent molars with bulbs exposed during carious tissue removal. 1 year follow-up, randomized controlled trial, Journal of Endodontics 2019. Conclusion: teeth with carious bulb exposures and reversible bulbitis can be treated successfully with direct bulb capping. MTA proved better than calcium hydroxide in terms of post-success rate and pain intensity. Systematic review and meta-analysis, Journal of Endodontics 2015. Direct bulb capping with calcium hydroxide or mineral oxide aggregate, a meta-analysis. MTA has a higher success rate, results in less pulpal inflammatory response, more predictable hard tissue barrier formation. Pre-mixed bioceramics, our bioceramic putty, a novel bulb capping agent. The pre-mixed bioceramic material possesses favorable results and all the properties comparable to the currently recommended material for bulb capping, MTA. The results are comparable or even superior. Pulpotomy of symptomatic permanent teeth with carious exposure using mineral oxide aggregate. Conclusion: pulpotomy using MTA could be a good alternative for root canal therapy for managing symptomatic mature permanent teeth with carious exposure. Success of coronal pulpotomy in permanent teeth with irreversible bulbitis. An evidence-based review. Coronal pulpotomy is an evidence-based, safe and predictable treatment that can be offered to adult patients in teeth with irreversible bulbitis and as a substitute to root canal therapy. Again, vital bulb therapy in permanent teeth diagnosed with symptomatic irreversible bulbitis. Reports with long-term controls. Vital bulb therapy with partial or total pulpotomy using bioceramics under aseptic conditions is a viable treatment that will have long-term success in permanent teeth with irreversible bulbitis when indicated correctly. Australian Dental Journal, this was in 2023. Vital bulb therapy for permanent teeth with diagnosis of irreversible bulbitis, biological basis and outcome from a bulb biology perspective, and based on data from clinical trials, partial and full pulpotomy using calcium silicate cements are successful treatment modalities for teeth with carious bulb exposure and symptoms indicative of irreversible bulbitis. Look how many teeth were saved. These were condemned to do root canal treatment. Remember, the best root canal treatment is the one you can avoid, and the best obturation material is what God's created, which is the dental bulb. With root PT as a root canal filling material, you can do complete root canal system obturation using the body material. Like in this case, I did complete root canal filling using the body in the distal root of lower second molar. I did this case 5 years ago. 2 years after, the patient came complaining severe pain related to the tooth. After I took a radiograph, I found a radiolucency related to the distal root only. So I did retreated the distal root only, and I filled the whole root canal system using wood root PT. And here is the clinical research that supports the procedure: selective root retreatment, a novel approach. In case of trauma case, this is a traumatized upper central incisor where we filled the whole root canal system using the bioceramic putty. Again, this is another trauma case where we filled the whole root canal system using wood root PT. You can also make a putty plug the last 3 to 4 millimeter, but here I did complete root canal system obturation. In this case, I did apical plug. This is a massively traumatized upper central where I did apical plug to the last 3 to 4 millimeter. In this case, also has an open apex. After we retrieved the overextended gataperca, we did wood root PT bioceramic putty or apical plug. Here also we did complete root canal filling using the putty material. And this is what I do in apexification procedure. You don't need any sophisticated instrument, just hand plugger, paper points, gataperca points, just gently packing the material, and you're done. Here I used hand plugger. Here I use paper points to adapt the material. That's it. You don't need any more, and you're done. Extremely curved and long roots upper second molar. This is a case of upper second molar with severe curvatures. This is a master apical file. This is the immediate post-obturation using wood root ST in conjunction with gataperca. Which other technique you can do such obturation? You can do even lateral compaction or warm vertical or any thermoplasticized gataperca technique. Just inject the sealer, put your master cones, sear off the gataperca, and you're done. This is another X-ray view. Bulb stone and multiple radiolucency management with 3, 6, 10, and 24 months recall. Shows healing, 1.53 year recall for direct bulb capping. If you remember this case, we did direct bulb capping for the second premolar. There were a hole in the crown leaking food, led to caries, hence bulb necrosis. After I removed the crown, I found a bulb stone blocking the canal entrance. This is a bulb stone radiographically, and this is the bulb stone clinically. We did root canal treatment. This is immediate post-obturation. The X-ray on the right is 3 months recall, shows significant reduction in radiolucency size. 6 months recall shows more healing. 10 months recall shows almost complete healing. And this is 3-year recall, shows complete healing, and for also the direct bulb capping. Calcification management. Look, it's very shocking when you take a radiograph like this. Oh my God. I managed to find the mesiobuccal and palatal canals first. After that, I was able to detect the distobuccal canal orifice, which was in a bizarre location. Look where I found the distobuccal orifice. Here, it's on the distal marginal ridge. This is a tiny perforation occurred during search, which was repaired later using the putty. And this is the immediate post-obturation and perforation repair using both the sealer and the putty. Hydraulics power. Bioceramics are a real savior and a game-changer material. How? How bioceramics changed our practice? Let's find out. Perforation repair. This is a male colleague who came complaining severe pain related to his lower second molar. After I removed the cataperca, I found a tiny perforation in the furcation area. After detection of the mesial canal, confetti X-ray, this is immediate post-obturation and perforation repair using the sealer. It's a tiny perforation, so I sealed it with the sealer. This is a 1 year recall. The tooth was completely asymptomatic. This is another large perforation which was repaired using the putty material. This case I did 5 years ago. I decided to repair this perforation using the putty to follow up the case. The 4 year recall shows the putty is still the same, did not washed out, did not resorb by time, which is a very tough test for any bioceramic material. It is subjected to the oral cavity environment. The putty can be easily washed out. Despite that, the composite at the distal margin was ditched, which is very weird. This is a referred case from a colleague for perforation repair and for inability to find the mesiobuccal canal. This is a file in the perforation site. This is a perforation site periphery. After removal of the granulation tissue from the perforation, after detection of the mesiobuccal canal, confetti X-ray, immediate post-obturation, immediate post-repair, and this is the immediate post-X-ray. This is the X-ray on the right is 1.5 year recall, shows complete healing. External root resorption. Such cases are condemned to extraction before the putty material. This is a case of lower first molar with massive external root resorption. This is the immediate post repair. This is the 6 months recall, shows significant reduction in radiolucency size, and the patient was completely asymptomatic. This case also was for a female colleague, a female dentist, who came complaining severe pain and swelling related to her lower first molar. Upon taking a radiograph, I found a large radiolucency related to a massive external root resorption related to the distal root. We decided to give the tooth one more chance. We removed the cataperca, and this is a large H file in the resorptive defect. Look at the size of the resorptive defect. I decided to obturate the mesial root first. So I blocked the mesial root first because it was oozing blood and exudate. So I obturated the mesial root first. Then I did the same for the distal root, and this is the immediate post-repair. This is how external root resorption may look alike. It has a regular shape. The 4 months recall shows significant reduction in radiolucency size, and she was completely asymptomatic, and there is no swelling anymore. Actually, this is a very tough test for any bioceramic sealer to withstand such tough circumstances. The sealer can be easily washed out. I have exudate, I have blood. The sealer can be easily washed out. But thanks to the consistency and the high percentage of the calcium silicate that allows the sealer to set without being washed out, there is no way to achieve hemostasis non-surgically. This area, you cannot. 8 months recall shows more healing, and this is a conclusion from a study that was comparing different PC sealers worldwide. They found that root ST was found to be the most effective for attachment of human periodontal ligament stem cell on the set surface. Day 0, 4 months recall, 8 months recall, 2 years recall shows complete healing, and the sealer still the same, did not washed out, did not resorb. Intentional replantation and the crack management. I did this case in 2013. I did direct pulp capping using calcium hydroxide. Unfortunately, in 2017, signs and symptoms of apical periodontitis started to appear. We did root canal treatment. In 2019, the tooth almost completely healed. Unfortunately, in 2021, after 2 years, horizontal crack pattern started to appear, half circle shape. This is indication for a horizontal crack pattern. After I accessed the tooth, I found the crack line stained using the methylene blue dye. We decided to give the tooth one more chance. So I removed all the cataperca and I filled the whole root canal system using the putty material. Unfortunately, the patient still have symptoms, so I extracted the tooth, cut the apical part of both roots, then put back again into the socket. And this is the 3 months recall, shows significant reduction in radiolucency size, and of course the patient was completely asymptomatic. This is a referred case from a colleague for management of a separated file in a dilacerated mesolingual canal of lower second molar. Accessibility was tough. I wasn't able to neither bypass nor retrieve the separated file, so I did disinfection, extracted the tooth, cut the apical part of both roots, then put back again into the socket. Lateral canal scouting. During scouting of the distal root of lower first molar, a lateral canal was detected. Look here. A lateral canal was detected. Unfortunately, the hand file was separated inside. This is the hand file inside the lateral canal. Now what will you gonna do? After I injected the sealer flows beyond the separated file here. So the problem was fixed. Here's a negative X-ray view. Here also, after we scouted the distal root, a lateral canal was detected that was easily filled with the sealer. Here again, during a scouting trial, a lateral exit was detected that was easily filled with the sealer. Okay, this is our last part, which is very important for non-microscopic clinicians. How to manage deep splits for non-microscopic clinicians. This is a case of upper second premolar with Vertuschi type 7. Vertuschi type 7 has the anatomy of 1, 2, 1, 2. This is Vertuschi type 7. 1, 2, 1, 2. Mostly the difficulty in the one part apically. Every time you go through the file hitting somewhere, you can't go. So I will tell you some tips and tricks to manage such anatomy. Number 1, stick to the reference point. Buccal cusp, palatal cusp. So be adjacent to the buccal or the palatal. Number 2, recurve all your instruments, your hand files, your rotary files, your gutta-percha points. Every tool you're gonna use, recurve it. Okay. Number 3, shape both canals together. Shape both canals together. What I mean by shaping both canals together, when you start shaping of the buccal canal, for instance, 2004 rotary file, after you finish shaping with the 2004 for the buccal, you do the same for the palatal. 2504 for the buccal, 2504 for the palatal, 3004 for the buccal, 3004 for the palatal. Because if you fully shaped one canal to the master apical file, and then you started shaping the other canal, every time you put the file to start shaping the unshaped, the narrow canal, the file will tend to enter to the larger canal. So you will find difficulty to enter the other canal. The one part that locates apically, you will find difficulty to enter this part. You will always enter the larger one. So if you shaped both together, you will find it's very easy. So both are getting shaped together, one by one. Okay? And that's what I meant by shaping both canals together. Number 4, of course, hydraulic condensation. Hydraulic condensation technique. Recurve your injection tip, inject your sealer, recurve your gutta-perca cones, and you're done. And of course, for the irrigation and activation use of the plastic or polymer needles for irrigation and sonic activation for the activation. This is an upper first premolar with the same scenario. Vertucci type 7 has an anatomy of 1, 2, 1, 2. Look how constricted the one part that locates apically. Same scenario, Vertucci type 7, 1, 2, 1, 2. This is another type of splitting, buccal and lingual canals. You will have to enlarge your access cavity buccolingual. Same here, another type of splitting. Okay. This case has another different scenario of splitting. As you see from the pre-operative radiograph, one main canal and two tiny splits are obvious in the radiograph. Okay, now we will start scouting. I cannot see. I don't see anything. I will start scouting. I found one main canal. I put my file, then I go to take an X-ray. Again, I put files, then I go to take an X-ray. Till I detected the two splits. I cannot see, so the thing that will make me see is an X-ray. So I found these tiny splits. This is a 4004 rotary file for the main canal. Now, how I will obturate these tiny splits? I cannot see, I cannot fully shape. I tried to make Getaperca harder, so I precurved and put on an ice cube and sprayed with endo ice to make it more stiff, hoping to put these Getaperca cones in the splits, but unfortunately I wasn't able. I couldn't put these Getaperca cones in the splits. So I decided to depend on another strategy, which is the hydraulics power. I chose the largest Getaperca cone that gives me the toughest tug back. This Getaperca cone here was 4506 Getaperca cone. Then I down bagged the cone till the level of the splits. So I blocked the main canal first. After that, I injected the sealer and added the rest of the cone. Look, the sealer started to flow through the tiny splits, and there is another lateral canal was getting filled with the sealer. We weren't aware if that exists. After that, I added more sealer and added tapered auxiliaries. Taper 4, we don't use taper 2. This step is very important. You have to sear off the Getaperca at the orifice level or beyond the orifice level by 2 millimeter and do some coronal compaction. That gives more hydraulics to the bioceramic sealer. Look here, we have heavily filled and buffed splits with the sealer depending on the hydraulics power. This is another level of splitting for the lower second premolar. During scouting, 3 splits were detected. I cannot also see. This is by tactile and X-ray. Master apical file. Unfortunately, a rotary file was separated in one of the splits. I tried to bypass. I managed to bypass part of the separated instrument, but I couldn't fully bypass. Look how hard this bypass. It's very difficult. But I couldn't fully bypass the separated instrument. It's very tight. So I decided also to depend on the hydraulics power. This is a confit X-ray. The immediate post-obturation, the sealer flows beyond the separated file. And this is the immediate post-obturation for both the lower first and second premolar. This is another level of splitting. This is what we call 3D obturation. This is a different X-ray view for the same tooth. Look, we have almost all exits filled with the sealer. This is the hydraulics power. Okay. Our last case. This is a case of lower first premolar that was a part of a bridge which has multiple splits. During a scouting trial, I put my files and go to take an X-ray. Took more file, take another X-ray. 2 splits were detected, 3 splits were detected, 4 splits were detected. This is a master apical file for the splits. Cone-fit X-ray, and this is the immediate post-obturation using root ST in conjunction with getapercha. And here is a quote from my mentor, Dr. Alan Nasih. If you're always worried about failure, you will never reach out for success. Thank you so much, ladies and gentlemen. I hope you enjoyed the presentation. Thank you. Thank you.
Thank
Any
you so
question?
much, Dr. Mina, for
Thank
such
you.
an insightful presentation.
Thank
For
you.
the participants, we have